So what I'm saying is if he's corkscrewing the ground from the foot, so it's a bottom up thing, then he's going to get medial knee pain. As he is continually twisting the tibia out more, that, let me show you here. Okay, what happens is he's corkscrewing the ground like this, and it keeps on going and going and going. And so now the femur starts to get pulled with it because he's got no more room to turn the tibia. So now the femur starts to turn. If the pelvis dumps up and over, it goes forward, that's going to create an ER at the femur itself, right? So let's start this. Pelvis dumps forward. That starts to ER the distal tibia in a fake, distal femur in a fake way. So that's turned out. Now what I start to do is I've got so much weight going on this right side because maybe I'm a right oblique, or I do something, maybe I play a sport of some kind, whatever it is. And now what starts to happen is I start to twist my foot. I start to corkscrew the ground with my foot because my center of gravity is so much on the outside of my foot. I start to try to twist my foot out so I get on the inside, so I orient my foot. Does that make sense? It's like I twist my foot out so that I can get this pronation. Fake pronation. So I keep on going, start to get a bunion on that right big toe. And then this tibia continues to turn out because of the foot. And then eventually I now create this too much gapping or space here that now maybe the meniscus gets tugged on, or maybe the VMO or pesanserin or all these things start to get pulled, right? Does that make sense?
Yeah.
So if you look at like an x-ray, for example, what you may see is lateral compression of the knee. It's like they've got a gapping like that. But this space gets closed because this starts to turn so much, it grabs onto the femur and starts to externally rotate it more, and it keeps on bowing. And now, so now the kneecap goes up and out towards the greater trochanter.
And how's the ITB story fit in with that, the lateral side?
The ITB starts, so this would be second, this would be like secondary. The medial, the lateral knee pain would just be pelvis dumps forward. That starts to twist things out, but the foot doesn't keep on going out. The medial knee pain is like end game leg. So
oh, I see.
Normal lateral knee pain is going to be a toe off of the foot. So they're like, end game. They like keep on twisting that tibia out more and more and more. The whole leg starts to twist out. Then I get that compression on the medial side of my knee because, you know, maybe the patellar tendon's getting so twisted. Maybe the, like I said, meniscus is getting like banged up. The MCL is getting over lengthened, all that stuff.
So is it a fair question to ask in the conversation we had about step downs and all that stuff and step ups, which of those kind of variations, which of those moves might you use more for the medial versus the lateral knee pain? Is that a valid question to ask?
It's not fair to ask that one.
Okay.
Okay. That's a tough question. Yeah. So you probably do, if you had like if you had the medial knee pain, you'd probably do the Peterson step down first, I should say. Okay, because what you're going to feel with the Peterson is you're going to feel a lot more VMO and tibialis anterior activity. Okay, if you had the lateral knee pain, you could get away with starting with the step down. You know, I wouldn't go 12-inch box, of course, but I'd probably go like a supported step down of like a 6-inch box where they're able to touch their heel on the ground. Okay, and the reason is because the step down again is going to posteriorly rotate the pelvis because I'm going to start to open up the space. The thing is, when this femur keeps, or this tibia keeps on twisting out because the foot is corkscrewing everything out, right? So let me see if I can do it on myself without hurting myself. So it's like, okay, pelvis goes up and over forward. So I start to get a little bit of a varus. See that? Then I start to turn more with the foot like that. It's hard to hold. But then I start feeling this pull right there. Because now what happens is the adductor starts pulling excessively, and I start to get some pain right in that medial knee. Right? Does that make sense? So it's like
Yeah, it
the
makes sense.
pelvis comes up and over, so now I get a varus moment, right? And then I'm still up and over there, but I keep on going. So now this foot's corkscrewing to try to keep me on the inside of my foot.
Who might the walkthroughs be more suitable for, or the ones you post, the one you posted on Instagram,
The lateral knee pain.
lateral knee pain.
Those people won't be able to control the forward and back.
Yeah.
Those people are like, you know who you're going to see this on is like a lateral orientation or an end game. That's set like the medial knee pain. That's secondary corkscrew. So to answer your question, Ivan, you're going to have to go after the right side first. You can't do bilateral stuff with that person yet. You're going to have to open up the right trochanter first.
I had him lay down on a foam roller on the right sideline,
Good.
like to start off.
Nice.
And honestly, he's been improving with the pain. Like every time he comes in, he's improving. I at the top of my mind, I can't remember what I gave him. I did honestly, I think I gave him a lateral squat, because I was like, I just based on like my limited knowledge is like, okay, like he's obviously compressed. Let's just go side to side stuff.
Good. Good.
Like the whole simple limited foam roller stuff. I think I had him do like the drunk walk, and
Nice.
I'm not sure, because I was like, okay, I don't know if that's grinding his knee or something, because like his foot is stable on the wall as he's like coming up and over. It didn't hurt him, so I think it was fine.
Which foot did you have on the wall?
Was his knee on the ground?
He's laying on the ground on the right
No, but
side.
like what I mean is like, so he's laying for the drunk walk. Let's say he's laying on his right side, his right foot's against the wall.
Yeah.
And you say, hey, push on the inside part of your foot. Does his knee come off the ground?
I think I can't answer that. I think it's tough for him. Like he's probably not even straight leg at that point.
Probably can't get, yeah.
We know which one actually I had him do is the walk over with the foam roller. So it's like the first session was like, okay, just lay down. Second session, I was like, well, I still don't know what to do with you. Now you're gonna do walk over.
Yeah.
So we're gonna do like a little bit more of a, like, just to give him a little bit something different, but still doing the same thing. Yeah. I'm like, I'm gonna do this until I talk to Alex.
Yeah.
But no, I had him do a lateral lunge after that, and
so you can't use the foot. Can't with someone like that, where they're corkscrewing that leg, you can't use the foot. So the walkover was a good option, because you get to start smushing the pelvis. You open up. So remember, if I take a foam roller, or let's say a towel, okay, if I take a towel and put it on the upper edge of the pelvis, okay, I'm going to open up this space here. If I take the towel and put it right on the greater trochanter right there, then I'm going to start to open up this space. Okay. Or another way of saying it, let's take an SI joint belt, put an SI joint belt on somebody right around the top of their pelvis. That's going to open up this. If I take an SI joint belt and I put it around the lower part, that's going to get the femur motion. You could do that with some people. Let's say, Ivan, I don't know if you have it in your clinics, but let's say you've got an SI joint belt there, and you're like, look, this person is so ER'd. They got varus on both sides, just like your guy. You know what I'm going to do? I'm going to put that SI joint belt on him. Then I'm going to get him to do, a walkover or something. Do you know what I mean?
Yeah.
Because then I can get some IR at the pelvis, and then I can start to use the feet to integrate it. But what I'd probably do, Ivan, is you're right on about the foam roller walkover. I would superset it with you doing something manual. And what I would do is get him to lay on his back, supine, his left leg straight. I don't care about his left leg yet. Left leg straight, and line his left side of his body with towels. So his left side is higher and he's laying on his right side. Right knee is bent. Then what I want you to do, it's like a hook line. Then what I want you to do is I want you to sit on his right arch, like sit on the midfoot, as if you're sitting on his laces. Then you take your leg and you do tibial IR moves. Okay?
Yeah. Okay.
So you probably know a couple tibial IR moves, right?
Yeah.
Okay. But what you're going to do is by sitting on his midfoot, you're not allowing his foot to turn out, which he wants to do. You're causing the force to go into pronation of his foot. Your one hand is going to stabilize the distal tibia. So you're going to hold it there. The top hand is then going to IR or do whatever you want to do to IR the proximal tibia. Okay, so what I've done there, I've lined up the left side of his body. That's put his left side into a later IR toe off. Okay, just because that side's off the ground and he's rolling onto the right side. By putting him in a hook line position, you've now opened up the front of the ankle. So you've biased it more towards tibial IR. You've sat now on his arch. You've now biased it into pronation, true pronation. And then you get a proximal tibia IR by pulling it. So now you've got sacrum open just by the towel, allowing you to roll onto that side. Then you got the foot stabilized by pronating. Now what you can do is you can twist the knee so now everything's lined up. See what I mean?
Yeah, I also had him do like the quarter squat. So like when I give him a lateral lunge and a quarter squat, technically he's using his legs. Is that not okay at this moment?
As long as you unweight him.
Just give him a TRX or something?
Yeah, exactly. Quarter squat's fine because you're technically unweighting him by allowing him to lean back. And his feet are in front of his body. Right?
Yeah.
Okay, so that's okay. That's good. That's all right. You're unweighting him. What you could do is while he's doing it, he maybe has his hands on a table, hands on a chair or something.
Yeah.
Further push himself back into the wall. Therefore, you're supporting him and that unweights his feet a little bit. Lateral lunge is maybe too hard because what you're going to do is if he can't bend his knee, therefore he cannot extend his knee, he's not going to be able to push himself to the left or whatever side he's going towards effectively.
In this case that you were talking about, like the hook line, kind of like getting him to do a little bit of tibial mobilization, would that not work for a valgus knee too? Because like a valgus knee, you have the femur internally rotated, tibia externally rotated. If you got a valgus knee, if a person is lying in a hook line and you kind of mobilizing that, wouldn't that kind of like drive the same thing?
Here's the difference. I would use the foot. I wouldn't sit on the foot.
Okay.
So I would, with a valgus, you're okay to use the foot to get the hip. With a varus, the foot and hip are not communicating with each other. So they're trying to go out that way. A valgus is going that way. So it's easy for you to reorient by saying, hey, push on the inside of the heel, push on the med head. All right, make sure the tag's on the ground. Okay, now all you got to do is just IR the tibia a little bit. So much easier. You may not even need to do it, you know, but a varus, you can't use their feet. You got to use their feet. They can't use their pelvis. You got to position their pelvis, and then you do the tibia IR mode or however you want to do it. You know, for somebody who isn't doing manual, you do the foam roller walkover, then you do the tibia IR walkover, or you're like foam roll the tibia. You know what I mean? They feel like they're doing a tibia shin splint thing, you know, or like a foam roller shins. And then you do a wall squat, right? If the right side is more varus than the left, then maybe you do a staggered stance with the right foot slightly back, left foot slightly forward. just to start.
Thank
Would
you,
it
Alex.
help-
I gotta
Would
go.
it,
Of course,
would-
I
just a quick one on that, Alex. Would it help his lateral lunge, even though it's not ideal, if he used a ramp on the side, so to get the foot to
Yes.
pronate on it as he steps out?
yes, he could do that. He
Yeah,
could do
yeah.
that. Yeah. Like on the foot that's pushing it, like if I'm going right to left, like the foot that's pushing, right, on the right side? Or the
I
left
was-
side, you're
I
talking.
was thinking left side, but now that you mention it,
So the reason why I'm saying that is because remember the varus needs to ER the distal tibia, which is what the ramp is going to do. I'm sorry, are you talking about toes elevated or heels elevated?
I'm actually talking about like a lateral elevations, like you step into, you're doing a lateral lunge.
Oh, yes, you're right. Yep, that would be
Yeah.
great. That'd be
Yeah,
good. that'd be
and
good
you're
option.
stepping into a slight elevation,
Yeah.
lateral elevation. Yeah,
I like that. Yeah, that'd be great. That'd be awesome.
to get
Yeah.
that same pronation you were talking about.
Exactly.
Yeah.
And then you can use a contralateral load as a way to, that's going to ER the femur.
Yeah.
Do you know what I mean? It's like he's going to sit back, or you're going to sit back and you're going to get the IR from going into that side. So I'm going to my left side, going into my side. The ramp's like this. Okay, great. Now I've got the tibia to IR, I've got the foot to IR, but the distal tibia has to face straight ahead. Otherwise, because like I'm going like this, right? The distal tibia has to go like that basically to face straight ahead, which is ER, if you want to call it that, you know what I mean? So the knee can bend, otherwise you're kind of going like a varus again, you know what I mean, to offset it. But then I've got the load going like this, which is going to ER the femur. So you'll get all of it. That's a good option. I like that.
Cool.
Yeah, it's a good one. You can do that with a cable chop as well, but you probably easier to do contralateral low with that, I would say.